Okay, since we have people from different time zones, so good morning, good afternoon, good evening for all of us. So I'm so excited to have our very first case conference in the East Asia regions. And we can see here that we do have colleagues from countries in the region. So we have colleagues from the Philippines. Hi, Emma. From Malaysia. Hi, Nizam. And of course from Indonesia. But I don't really recognize other names. Maybe if there are other countries in East Asia regions, maybe it's, I don't know, it's just a suggestion. Maybe if you can go change our name to our nickname and country so we can know who from where. So I will start with mine. And rename. Yeah. Okay. So thank you everyone for coming to this case conference, and thank you for, of course, my colleague from the Education Committee of IAAH to support this program. Before we start with our case presentations, I think I would like to give an introduction of the program so we can learn together what is the purpose, or what is the program, and what is the purpose of this program. Okay. Nice. Share my screen. Okay, so this is our case conference. It's actually this is the second pilot of the case conference. The first pilot we did it with internally within the Education Committee of IAAH. So this is our very first initial case conference with audience of other colleagues outside the committee. So for those who are new to IAAH, so IAAH is International Association for Adolescent Health. It is a multidisciplinary non-government organization which aims to improve the health, development, and well-being of adolescents aged 10 to 24 in every region of the world. Since its inception, IAAH has been committed to evidence-informed practices and policies and to ensuring that young voices inform our work. I couldn't find the data from the specific East Asia regions, but from the East Asia Pacific region, there are at least 329 million adolescents, making up a quarter of the world's adolescent populations. And we do know that adolescent health has been growing as an emerging field, appreciating that investments in adolescent health bring triple dividends across the life course for the adolescents themselves, for their future adulthood, and of course for their future offspring. Many countries have no or very few formal training opportunities around adolescent health. There are actually opportunities for formal fellowship or training programs in other countries, but they are limited. And we also do have webinars and scientific meetings, but they do not always address the need for clinical competency. So the Education Committee of IAAH proposing an online learning platform to discuss new or challenging cases, or basically any cases, any adolescent cases, with clinical experts from different countries, with the goal of providing a safe space for learners to review the clinical management of their adolescent patients. So we aim to have like a small group discussions to learn together about that specific case that proposed by the learner. So that's why we a bit limited our participants. So we do not aim to have a large webinar, but it's a more to small group discussions. So I got it from Emma. Thank you, Emma. This is just a general informations about the situations of formal training and educations in our regions in the East Asia. So there are there are some countries which do not have formal training or educations in adolescent health and medicines, but I think this is not only in East Asia regions, but it's everywhere in the world. It's globally that formal training and educations in adolescent health are limited. So again, the aim of this conference is to provide clinical peer support. So we help each other to enhance the adolescent case management. To note that each learner or presenter will determine their own learning objective and challenges to be reviewed and discussed. So the output of this program is to have a regular case-based clinical discussions within each IAAH region. But it can also, of course, involving more than 2 regions, as long as the time zone is comfortable for everyone. So basically, we help each other. It doesn't always have the whole regions, but it can also some countries. But in the tour we just mentioned the IAAH regions. And as of course, we need evaluations to improve our program. So at the end of each sessions, there will be a just simple Google form evaluations from participants. So please do help us to improve the program by fill in a Google form evaluations that will be provided at the end of our sessions. So I think that's all a little background of our program. So let's start with our case discussions. The case will be presented by Dr. David Anggara from Solo, Central Java, Indonesia. And I would like to express my gratitude to Dr. Hari, the head of Adolescent Task Force from Indonesian Pediatric Society, who has been so kind and helpful in facilitating and preparing the case presentations. Time is yours, Dr. David Anggara. 15 minutes.
Thank you, Dr. Siska. I will share my screen. Is it clear, my voice and my screen? Okay, thank you. Hello, everyone. Good afternoon. My name is David Anggara, and today I'll be presenting a case discussion titled An Adolescent with Multi-Drug Resistant Tuberculosis and Unspecified Behavioral Syndrome, drawing from a case study in Indonesia. This case highlights the complexity of managing tuberculosis in adolescents, particularly when compounded by psychosocial challenge. To provide context, let's briefly look at the situation of adolescent tuberculosis in Indonesia. Indonesia faces a high national TB burden, ranking among the top countries globally, with estimated about 800,000 cases in 2020. While specific national data for adolescents aged 10 to 19 are somewhat limited, studies indicate a notable prevalence in the 15 to 24 age group. Adolescents also face specific risk factor for developing TB, including household exposure, environmental condition, nutritional status, and psychosocial factor. This case we will discuss today unfortunately touch upon several of these aspects. Before we delve into the detail of the case, it's important to outline our main learning objective. Firstly, to understand the potential psychosocial issue in adolescents with chronic illness. Secondly, to appreciate the importance of a holistic approach and multidisciplinary collaboration in managing adolescent patients with multi-drug resistant tuberculosis. Our case involved a 15-year-old female adolescent weighing 48 kilograms. She was referred from a regional hospital presenting with a history of persistent cough, fever, and decreased appetite and body weight. Initial investigation on March 2024 using expert MTB Rift Ultra detected the presence of Mycobacterium tuberculosis, but importantly, rifampicin resistance was not detected. This led to a diagnosis of new case bacteriologically confirmed drug-sensitive tuberculosis. The patient was started on the standard first-line TB therapy. Her progress was monitored and evaluation of acid fast bacil at 2, 5, and 6 months showed negative result, indicating a positive initial response on treatment. She completed her therapy in August 2024. Unfortunately, on November 2024, the patient complained of productive cough, fever, and shortness of breath reappeared. Additionally, she reported new symptoms such as difficulty sleeping, irritability, and anxiety. Distress concern about potential treatment failure or relapse. Further investigation were conducted by January 2025. January 2025, an expert Rift Ultra test detected Mycobacterium tuberculosis, but with rifampicin resistance detected. Subsequently, an expert XDR test further revealed low-level resistance to isoniazid and ethionamide. This confirmed the diagnosis of multi-drug resistant tuberculosis. The patient's family medical history is significant. She lived with her older sibling and sibling-in-law, a total of 3 people in the same household. Tragically, her father passed away in February 2022 due to MDR-TB, and her mother passed away in 2021 due to unspecified lung disease. This history of TB in the family, particularly MDR-TB in the father, is a crucial factor in understanding her current condition. Regarding her physical health, her nutritional status based on CDC criteria was concluded as well-nourished but stunted. Her immunization status was reported as complete according to the National Immunization Program of Ministry of Health, Republic of Indonesia. From psychosocial screening based on health screening, the adolescents currently reside with her older sibling after previously living in a conflict-prone household with her late parents and stepmother. She reported a history of physical abuse by her father and emotional discomfort under her stepmother's care. She attended Islamic school but dropped out in 3rd grade due to a minor conflict with a peer and resumed her studies online 2 years later. She doesn't have close friends at school and find memorization-based subject challenging. Her physical activity is minimal with no regular exercise or hobbies. She spent around 5 to 6 hours per day on her phone. She reported a healthy appetite prior to illness, but has experienced significant weight loss following her MDR-TB diagnosis. Emotionally, she experienced a period of hopelessness after losing both parents, but regained motivation through her supportive relationship with her sibling. She also went through emotional distress after being left by someone she was emotionally close to. She has no history of substance use or bullying, but has experienced domestic violence and emotional neglect. No active suicidal idea is reported currently, but sign of previous depressive thought exist. Uh, a comprehensive psychosocial screening reveals several significant risk factors in various domains, from home, history of physical abuse by her father, exposure to frequent parental conflict, emotional neglect from her stepmother, and the loss of both parents. She also tend to keep her emotional to herself. From education, drop out of school after grade 3 due to peer conflict and experience a 2-year gap before resuming education, significant weight loss due to illness, no engagement in physical activities or hobbies, and high screen time. From sexuality, emotional distress following the loss of a close male companion, and history of domestic violence and emotional neglect, reported loss of motivation to live after parental death, and occasional feeling of sadness and crying alone. Despite this challenge, the screening also identified important protective factors and strengths. Current living arrangement with a supportive older sibling and removal from the previously abusive environment, resume education through online learning and return to school, indicating learning motivation, participate in regular religious gathering, which may provide social and moral support, currently in a safer and more stable home environment, strong emotional support from her sibling, and the ability to identify source of motivation. This patient demonstrated resilience and adaptability. Laboratory results showed some minor deviation from the reference range. Imaging studies reveal suggestive of active pulmonary TB mixed with bilateral pneumonia. From baseline examination, provide further insight from cardiology, ECG showed sinus rhythm, but no sign of ventricular hypertrophy or prolonged QTC. Echocardiography was within normal limits. From psychiatry, she was diagnosed with unspecified behavioral syndrome related to physiological disturbance. No hearing loss was detected. From eye exam, so normal vision and ability to focus. Based on the comprehensive assessment, the working diagnosis were multi-drug resistant tuberculosis, behavioral syndrome related to physiological disturbance, short stature due to chronic malnutrition, differential diagnosis with familial short stature and endocrinology disorder, and the proposed case management include a short-term regimen with 6-month BPALM consisting of bedaquiline, pertinomide, linezolid, and moxifloxacin. For the behavioral syndrome, aripiprazole and guided imagery via audio were initiated. Furthermore, the centralization of healthcare and contact investigation were planned. The main challenge in this case are compliant to the complex and potentially long MDR-TB treatment regimen and the need for long-term psychosocial support to prevent future behavior issue due to adverse childhood event and family situation. In conclusion, this case underscores the critical need for a holistic and multidisciplinary approach when managing adolescents with chronic illness like MDR-TB, addressing not only the physical aspect of the disease, but also the significant psychosocial challenge for successful treatment outcome and overall well-being. Thank you for your attention, and I'm open to any suggestion about this case. Thank you, Dr. Siska.
Thank you, Dr. David, for thorough for nice presentations and a terrific health examinations. Yeah. Okay, so now we proceed to the discussions sessions. Before we hear from our expert today, Dr. Ruba and also Dr. Preeti, is there anyone in the room who would like to raise a questions regarding the informations of the case? Or maybe we can end the share screen. Yeah, thank you. Okay.
I would like to.
Yeah. Okay, Nizam, please go ahead.
Oh, okay. Siska, sorry, because just now I was I was on mute earlier on, so I could not respond. So, Siska, it was wonderful effort. It was a brilliant initiative by your team, and the case enlightened a lot of basic psychosocial tool, which was very gold standard in adolescent medicine, and it covers the demographic and what is the issues or the psychosocial issues, and also the management for the TB, which is quite common because we have almost similar demographic geographically, and the common TB burden in Malaysia is also increasing, and we are making more and more awareness for TB in Malaysia. So I think it was a very commendable presentation. It was, I think we all learned from the perspective of Indonesia and how the young person in Indonesia deal with a chronic illness of a very challenging. I can see the complexity getting the treatment along with all the family dynamics in getting the treatment. My question is, I'm just wondering about because the TB management has advanced. The last decade, and recently we are given we have more and more screening tool instead of tuberculin tests, instead of doing a man-2, we have more advanced screening, which more sensitive and more specific, like IGRA. I'm just wondering whether IGRA test is a common screening tool, because I'm sure this person with multiple drug resistance of TB, they may require a contact tracing and family screening. And there could be a false positive, whether that facilities is available. That's one in terms of investigation. The next step, of course, we're going to institute treatment given the medication and treatment for TB, and MDR-TB is very challenging with, it might need to be given more subspecialized kind of treatment for very anticipating of the difficulty of response to treatment, which could lead to a lot of complications systemically. So just wondering whether you have like the combination therapy of combination of 4 drugs. We have the basic accurate and the new advanced therapy of combination of multiple drugs in Indonesia. Probably that will be good sessions, Iska. Thank you.
Thank you, Dr. Nizam. Dr. David is our pediatrician.
David, yeah.
So
yeah.
please go ahead, Dr. David.
Yeah, so probably Dr. David can enlighten us about these few advanced available treatment for TB in Indonesia, Dr. David.
Okay, thank you, Dr. Nizam. TB is challenging, yes, of course, for a lot of countries. But in Indonesia, if multi-drug resistant TB, we have a short regimen and long-term regimen. If short regimen, we have BPALM, 6 months of regimen, or maybe 9 months of regimen. But if the patient got destructive lung or maybe severe multi-drug resistant, uh, we give a long-term regimen. Long-term regimen about 20 24-month regimen, and we give orally. There are no injection because the patient is a child, adolescent, so we give orally. And if the patient not severe, we give 6-month regimen or short-term regimen, about 6 to 9 month regimen, multi-drug resistant. Nizam, Dr. Nizam.
All right. Do you have the advanced investigation like IGRA for screening for contact tracing and family screening, or is it a BCG or
Oh,
a
okay,
tuberculosis?
okay. Yeah. For screening, we have TST and IGRA, but we choose TST because more easier, and then more cost efficient, because more we have a lot of TST in a lot of first healthcare facility. So
All
TST
right. Thanks.
first, and maybe if there are no TST, we choose IGRA. But for the drug-resistant tuberculosis, we must to examination with expert TB ultra or expert XDR.
All right. Thank you, Dr. David Anggara. I think that's very clear.
Okay,
We
thank you,
appreciate that.
thank you.
Okay, yeah, Malaysia and Indonesia, we shared epidemiology data, yeah, so we have
Yeah,
similar
very similar demographic and
demography of diseases. Okay, is there any other questions from the room? Yeah, Emma, Dr. Emma, please.
Yeah, again, David, thank you for that very thorough presentation, especially appreciated the heads like Riza did. Just two questions. Are you comfortable using the PHQ-9, the patient health questionnaire 9 for adolescents to screen for depression? Number two is that your concern here was more of the compliance or adherence. What were the factors specifically that uh, could have made it difficult for her to comply with the medications? Is this like an experience with a previous regimen, or you're anticipating that this will be a problem in the 24-month regimen that you're planning? Thank you.
Okay. Thank you, Emma. For the diagnosis of behavioral syndrome, we consult with psychiatry, of course. So maybe from psychiatry can explain after that. But the second question about the adherence of this treatment, uh, we contact her sibling, and then we contact the primary healthcare in the near of her home, her region. So we can monitor 2 weeks, every 2 weeks or every month, to achieve the adherence for this regimen, Emma.
Thank you, David. We should really recognize that adherence among adolescents it's a major
Yeah.
problem. Well, for everybody, it's estimated that only 50% of us really are 100% adherent. But this is a very complicated. It's a complicated issue, and a thorough understanding of the factors that you know could contribute to the non-adherence will also help us in, with the help of the adolescent for input, also uh, perhaps create solutions, possible solutions, so that she's part also of the planning for the adherence. Thank you.
Thank you, Emma.
Thank you, Emma, for the question. So regarding PHQ-9, actually in some of the adolescents clinic that we have in several teaching hospitals, we do usually use PHQ-9 as initial screening. But we have our psychiatrist here. Maybe Dr. Maharati could explain more about what is the usual screening tool that usually used in your daily practice, and in particular for this case, what was the screening tool that was used? Please.
Thank you, Dr. Rizk. I'm Maharati. I'm a child and adolescent psychiatrist. We usually use ICD-10 or the ASM for diagnose. We never using PHQ-9 in hospital. Yeah, never. Yeah, for diagnosis, because the PHQ-9 only screen and it's to I think it's not enough to diagnose the patient with depression. Yeah, especially in adolescent and child. And patient didn't meet with depression diagnosis, so we diagnose with unspecified behavioural, because this is come from the medical condition, TB MDR, and the drug, the MDR-TB medication induce the psychological condition in this patient. I think that's the reason. Yeah. Thank you.
Okay, maybe to add some context for these patients, maybe because these patients was treated in a referral hospital where child psychiatry is available. Maybe so, but we do still use PHQ-9 in places where child psychiatry is not available. Thank you, Dr. Maharati, for your explanations. Okay, maybe we can see Dr. David, if you can remind us what was your main questions. It was about the compliance, right? And the second one was the psychosocial support. Yeah. Regarding that, she had a quite serious adverse childhood events in her life, and a difficult family dynamic. So
Okay.
maybe
Yeah.
on that two questions.
Thank you, Dr. Rizka. This patient, based on her sibling story and based on the interview with the patient, she reported history of physical abuse by her father and emotional discomfort under her stepmother's care after the father passed away. But her sibling give motivation and full support to the patient. So the adherence, I think the adherence for the short regimen, it's okay, it's good for this patient.
Okay, thank you, Dr. David, because I see some participants are coming, new participants, so maybe it's just a little bit additional information for those who are just join our sessions. So is there any further questions before we proceed to our expert for today? For clarifications or for additional data from Dr. David? Any further questions? Okay, if there's no further questions, maybe I would like to invite Dr. Ruba and Dr. Preeti to give your review for the case, and especially in answering Dr. David's questions.
Dr. Siska, thank you, Dr. David, for presenting this case. I am Dr. Ruba Rizk. I am an adolescent medicine physician, currently living in Dubai and practicing at a specialty children's hospital in Dubai. The case that Dr. David is quite complex, because not only does this patient, she's been given a complex diagnosis that carries with it a lot of stigma associated. And she's already seen and witnessed the damage, I guess, that it can cause on the family with the death of her father, and more likely as well her mother. So she's experienced quite significant trauma. So that's one aspect, is that the condition that she's been diagnosed with on its own carries a heavy burden on such a young patient. Second of all is the psychosocial stressors that you detailed. Doesn't sound, she recently has a stronger support system. It's great that she's identified her sister. And then lastly, outside of her own personal social support system, is that there's, I'm going to call it, with the fact that she's not engaged in school or has disconnected from school, that lack of engagement or feeling productive, school gives purpose, especially to our teenagers. And it's important when we're addressing this case, and that's what we tend to do as adolescent medicine providers, is we look at every patient holistically and try to support them with our colleagues, every single multifaceted aspect. So one of the things that you mentioned was adhering to treatment. This is typical. Every single teenager, once they hit the teen years, they struggle with complying with treatment. They can be the most controlled diabetics, and then suddenly their HbA1c is skyrocketing. It's a time when we all know that they're developing their identity. There's that struggle with autonomy and them wanting to be independent, yet here they are, being told exactly what to do by providers without any say in the decision-making process. Parents are on their backs, and during this developmental period, it's pretty much the anti-parent, and the parent keeps checking in, and all they want to do is just stay away. It is innate in them that they need to fit in with their peers, and being given a diagnosis, already they're thinking, why me? When being an adolescent is, everything is why me. They are always the victim, and it's just they're trying to get themselves, and that's a whole part of that beautiful development that goes through, is putting things in perspective, walking in other people's shoes, etc. But they haven't achieved that ability to think in this, to perceive, relationships, all of it in there. And they're going through the process. It's important. So with regards to the adherence, we need to try and help support them. First of all, from your side, It's always important we involve them in every single decision and discuss the treatment plan that we have. And I use shared decision making with whatever I'm doing, you know, checking in with them. Does this work? If I have two options as a physician, involving them in the decision making, seeing which option works better. Do you want the medication you take in the morning and evening? Are you okay with the 4-time-a-day medication? It also makes them feel that they have a say in their own care. So we kind of get that buy-in into the treatment plan. And I think you have to build trust. They have to trust us as physicians. And if we don't have that trust, it's very hard to engage them in the therapy. And then we need to reduce the barriers and help them. So they're going to struggle with, I don't know, even maybe figuring out how to get the medication or how to come to visits, depending on where you practice. And then that lack of motivation, hard to, you know, get teens to just move sometimes, you know. So we have to, so finding that trusted person, creating a trusted relationship, forming a trusted relationship with your patient, so that they believe in you. Finding a trusted adult outside. So it seems from this case, it's her older sister right now. Who's that trusted adult that we can work on building or developing a plan together. Other, you know, motivational interviewing. I know we tend to throw that around, but it does help us. It kind of puts a structure to that visit, helps us see where they are. Does she want to comply? Does she not? What are the boundaries that she's putting in place to allow her not to take the medications in a timely or not come in for her follow-ups, etc. So you may need to tailor that treatment plan. I don't know what has happened, you know, what steps have you've taken in order to help improve her compliance. But these are just some suggestions. I usually tell them to recommend things, or we brainstorm together, because I don't know what their how their day-to-day life is. So for example, I'll tell them, do you have a phone? If you have a phone, would reminders work? Or do you prefer Post-its? Like, would you like to put a Post-it somewhere? Or if there's no young kids, could you put the medication next to your bed? And that way you'd remember that the first thing you do is take that medicine, or the last thing you do before going to bed. And we help work together, giving them several options to see which one they find they can comply with the most. And then I send them off and bring them in, because close follow-up is always important, and touch back and say, hey, so what worked, what didn't work in this plan? And sometimes, you know, you can just do a phone call just to check in. Hey, is it working? How many times this week have you taken the medicine? And breaking it down into small goals helps. So if she was taking it maybe once a week, you know, 5 days a week of taking the medication is a win. So if we can tell them, hey, you think you can try and take it 5 times a week, and if you skip it once or twice, that's okay. I think helping just break it down also supports them. Sometimes it's about a side effect of the medication. Sometimes it's about them not knowing enough about the medication, and this is where your expertise comes in, and just explaining what each medication is for and why it's so important, because they may not understand how important it is for them to comply. So I don't know, does that help answer? Or what are some of these strategies maybe that you've used or attempted during your interactions with the patient? And if anyone wants to add in, please do, for the adherence component.
Thank you, Ruba, for reminding all of us about to discuss that adolescents with chronic illnesses do have a stigma, and it's important for us to evaluate that within our interactions with adolescents. And thank you for the insight to improve compliance by shared decision making with adolescents, to help them become the agents for themselves. So maybe we proceed to Dr. Preeti as our next expert. Do you have any further comments or review?
Thank you, Siska, and congratulations, David. That was a wonderful case discussion. And to carry on from where Ruba left, I would say that, we were talking about behavioral issues, right? And if I could see in the history, the presentation was difficulty in sleeping, irritability, and anxiety. Right? So mental health falls on a spectrum. So we have mental well-being at one end. In the middle, we have a little bit of mental stress, a mental discomfort, then we have mental distress, and then we have a mental disorder. So I think we need to really carefully follow this adolescent because it could be an evolving mental disorder. And as you can see from the case history, there are a number of stressors. To just enumerate a few, yes, she's staying with her older sis, she has a history of ACE, she is out of school, we need to do a psychoeducational assessment here. Is there a learning disability? Are we missing out on that? Is there ADHD? Is there, of course, I'm sure we have the psychiatrist here. All those things would have been, kind of looked after. Then the second thing is the screen. If you see, she has an unhealthy screen use. Is she having an internet disorder, for example, so we have these small screening tools. You said PHQ-9. I would say for a primary care pediatrician like me, PHQ-2, just 2 questions. Patient health questionnaire 2, scared 5. Otherwise, we have scared with, that is screening for childhood emotional disorders for both the parent and also for the child is then it has around more than 40 questions. So we have scared 5. And then for a screening for internet disorders, we have PRIS-3, just 3 questions, problematic, risky, intern use screening scale. So if we can use these very short screening tools, they'll give us an objective assessment. And if the score is, of course, very high, we need to partner with the psychiatrist. Also, we have to look at her distress after breakup with the male companion. There's also if you've noticed in that. So when did her problem start after this? How much has it impacted her? So that's not very clear because loss of a relationship, the grief reaction after that can be quite intense for an adolescent. And you can see stressors can get down the T cell response and thereby the immunity and have huge impact on the response to drugs and medication in chronic medical disorder. So as we always say, there's the mind-body connect. So I think we really need to work on that if we want to really give her the full benefit of what we are treating her with now. And I would also go to the past history and see whether she was adherent in the first time. What were her challenges? Why was she not adherent? What are her goals for life? Instead of just piling on our goals onto her, it's very, very important to find out what does she want, right? And help her to achieve those. And as was mentioned, few strengths was she being very, very resilient. She wants a good life for herself. So I think they have to tap on those. And my first thing would be a healthy lifestyle. Take care of her nutrition. Take care of her physical. She has no physical activity. If you notice that, take care about the physical activity. Take care about the sleep, healthy media use, handle her stressors head on and help her to do that. And also partner with the older sib because she appears to be the caretaker or the caregiver. And of course, she will require a close, very close mental health follow-up, as close as what would be a physical health follow-up. And also a word about her social relationships because we know health is all about physical, mental, and social. So we need to, so for an adolescent, peer relations are so very important. So we need that as well. So I think this kind of, in very, very brief, sums it all up. And I know, David, I've given you a lot of work to do, but I think you have excellent Siska there and Maharat there, and I think you could kind of partner with them. And I'm sure you have a successful, kind of resolution of her symptoms, and she'll do well in life. Thank you. Thank you, Siska.
Thank you so much, Preeti, for a thorough review. Yeah. So thank you for to remind us about the mental health issue and the screen time issue of our adolescents. And also thank you for, reminding about the use of simple tool as an objective assessment to screen mental and behavior issue. I think especially for us as a general pediatric or primary care or secondary care, where child psychiatrist is not available. Even though we do have a child psychiatry available in the hospital, we can just do initial screening to decide whether we need to refer the patients to child psychiatry or to psychology or to other, more suitable professionals. And do you have any, and also thank you for the holistic healthy lifestyle. Yes, it's just not just physical, but also the mental health and the social health of our adolescents. That was the definitions of health from WHO, yeah. Physical, psychological, and social health. Okay, David, maybe do you have any further questions that you can ask to both of our experts today regarding their comments? Do you have more questions for them?
No, I think thanks to Ruba and Preeti for enlightening me about how to handle this patient, how to handle and how to motivate this patient to adherence the treatment and then to improve the daily life or maybe her quality life. Thank you, Ruba and Preeti.
Okay, thank you, David. So we still have some more time before we proceed to the evaluations of our sessions. So Preeti also highlight the importance of using the simple tool, but it was initiated first by Emma. Maybe Emma, could you share with us how is the role of using that tool, PHQ-9, for examples, or other simple tool for screening mental and behavioral issue in the Philippines? Maybe we can also learn from your experience in the Philippines.
Okay, thank you for that. The Philippine Pediatric Society recommends that we start a universal screening at the age of 12 for all adolescents who come to our clinic. However, we always say that do not screen universally unless you have systems in place, unless you have the services, unless you have the people who can take care. Otherwise, it will be just case finding. So that's the situation right now. We're also teaching our community health workers to do that, also with systems in place and a referral system, all the way to a mental health specialist. We always tell the pediatricians, of course, understandably, always say that's not part of our training. We're scared to do this. They might commit suicide if we talk about suicide and all that. So we have to also dispel the misconceptions. And they say, what can we do? We're not trained. And we say, there are basic things that you can do as a pediatrician. You can administer that, and it can even be self-administered by the adolescent herself. The other is that before sending off to a mental health specialist, you can do psychoeducation, as Preeti said. What is depression? What are the causes? There's treatment for it. People get well, and don't be scared of medications. So usually that's what we say. And then we also have to tell them that, there are things you can do to feel better. And we also mentioned that, just get enough sleep, move again, start moving. do something pleasant with friends, resume a hobby, cut down on your screen time. So these are all the things that a general pediatrician can do before sending off. And you know, a lot of our patients get better with just being listened to, and just just having their emotions validated and not dismissed, because in our country it's very common for them to be dismissed. You know, we never had depression in our time. Why are you guys so fragile? So that's what the young people are getting right now. So those are the things that we're trying to teach our primary care physicians. And of course, the aside from that is the self-care. Yeah. And if they have difficulty in sleeping, we prescribe melatonin. That's the safest, or hydroxyzine, just for them to get sleepy. But again, it's sleep hygiene that we need to emphasize without the medication as much as possible. So that's what we're trying to do now here in the country. Thank you.
Thank you, Ma, for sharing and for highlighting the importance of basic communication skill with adolescents, such as reflective listening skill. As sometimes they do also just need to be listened. Okay,
Can I just add one more thing, Siska? Yeah. So in adolescent medicine, we also practice anticipatory guidance, So especially with a child with resistant tuberculosis, I think talking a bit about smoking, about other substances also becomes important, even though there may not be any substance use currently. Right. So that I think we need to do it. That goes as a packet. And we need to also talk about sexuality education. This definitely she needs it, because she has. So even though there may not be a current issue, we also ask them, what do you feel? How do you feel? So all these things. So kind of in a very conversational style, always building a therapeutic alliance and encouraging bi-directional communication with a non-judgmental attitude. I think that makes a great deal of difference. Thank you.
Thank you, Preeti. Ruba, do you want to ask?
I'm going to add one thing to Emma's point about pediatricians, especially when they're really anxious about, screening for mental health issues or conditions that our teens have, especially when the fear is always if suicidal risk is identified. It's pretty important for our pediatricians to have a confidentiality statement and be comfortable letting their teens know that if they identify any danger to the teen or suicidal risk, that it's to discuss it with that trusted parent or the guardian. Sometimes if just by putting in that safety planning and having the teen have a plan that when they if the thought comes in, that they know exactly what to do, that I am to reach out to this trusted individual, my parent or my guardian, or an older sibling who can then communicate with an adult, it helps the teen. At least it helps the teen, because so many times with suicidal ideation or even true risk, it is about getting over that hump. And they just need the help to get over that hump, and then that risk dissipates for a little while. And if we as primary care providers can support that teen in knowing what to do next when they feel so down, I think we've already done a major difference, especially since suicide remains one of the main causes of morbidity within our patient population, morbidity and mortality within our patient population. So just having our pediatricians comfortable doing that is super important.
Thank you, Ruba, for highlighting the need for general pediatric to have the skill for very basic screening for mental issues, especially those that tend to be related to suicidal thought. So I think we've come to the end of our sessions. I have put a link of our evaluation form please to have everyone to fill in the evaluation form to help us revise, improve our programs of this case conference for in the futures. Thank you so much for Dr. David for the case presentations, and Dr. Ruba, Dr. Preeti for the expert, and also Emma for the guest expert for tonight. And maybe before we close our sessions, we would love to hear directly how do you see this event? Maybe I would like to invite Dr. Hari. Would you like to say some words about how do you see these events and how would you like us to improve the program?
Thank you, Dr. Siska. Actually, this is my first to join this case discussion in the IAAH. Yeah, I think it's very helpful for us, especially for pediatrician in Indonesia, to have this kind of discussion, because adolescents, as in other developing countries, in Indonesia, we can categorize it into the neglected period in our country. And based on our data, actually, the most common death cause for the adolescents in Indonesia still is infection, and the second one is the motorcycle accidents. Yeah, and it's second one. So again, the infection still the main problems of adolescents in Indonesia. So in the future, we are looking forward not only for the case discussions, Dr. Siska, but maybe we can increase our collaborations into the research together. So it's gonna be multi-center research, so we can give many recommendations for the adolescent problems in our country. Thank you, Dr. Siska.
Thank you, Dr. Hari. Dr. Hari is the head of Adolescent Task Force of Indonesian Pediatric Society, who facilitated this case presentations. So I would like to thank everyone who collaborate in this case conference. I would like again to remind all of you to fill in the form for us to improve the program in the futures. Thank you, everyone.